The imaging-based Gen AI's related technology. We haven't actually touched upon that as yet, right? So how do we actually connect these large language models to the databases, right? So I mean, if you have a bunch of data and you have like Llama 3.2, yeah, everyone can come up with some algorithms, but can these algorithms speak to your Excel sheets? Can they speak to your PDF copy? Can they speak to your SAP system, for example? This is a huge untapped space that not many developers are currently looking at that space. And of course, the large language models, as we know, they are very expensive. So Xian Hui was saying, of course, Manoj and Xian Hui, in our first panel, we talked about the increasing cost of how NVIDIA is getting more and more powerful AI engines to power charge. Now we're talking about ChatGPT 5.0. We're talking about Llama 4.0. Of course, whether or not the performance is as good right now, I think there's still time to actually, there's still a lot of time that's needed to actually prove that space. And coming back to the clinical space, I think the underutilization of the data that sits in the healthcare space, the data security, the difficulty in sharing data, right? Not just within the US and Singapore. No, I'm not even talking about that. Sitting in SingHealth to share data across institutions. I'm talking about as low level as that. We are facing challenges as well, right? So how do we actually look at the legacy AI system? So again, in SingHealth, we are moving to Epic. So how do we actually move to I would say a better EMR system, but at the same time still have flexibility to use our data? So those are the things that we are constantly thinking about. And of course, for AI, if you do not have data, you cannot train a good AI model. And the data itself has to be clean. It's not like, oh yeah, let's extract the raw data from an EMR system, and then I can build a bunch of AI algorithms. No, I mean the short answer is no for that. And Namrata talked about clinical trials, recruitment, and how do we encourage or how do we get the regulators to be less risk averse in terms of approving the IRB system, so that at least some experiments or clinical trials in the phase 1 or phase 2 space can happen in Singapore. And then it will result in a lot of the biotech companies that look at, hey, maybe instead of going to Australia, Singapore may be a good alternative, right? That is just in questions that we want to do. So today I want to announce 3 different new Gen AI initiatives that we have done in stealth for the last 12 to 18 months. First is Enigma. It operates and it functions in the software as a non-medical device space. And Mermaid and Elf, they're both Disney characters. People always ask me to come up with the easy to remember names. So I thought, yeah, Disney characters. Even my kids actually know what Mermaid and Elf is. So maybe I go with that. So Mermaid is a multi-specialty, multi-disease foundation model. See that as a sea lion type thing, but in the healthcare space for medical imaging. And ELF is something that not only that we're doing imaging, but we are doing reporting. So if you look at the radiology scan, and if you want to report, that is what we call the Visual Language Foundation models. I'm just going to share a little 3 slides for each technology we're doing here today. So Enigma is an AI automation for healthcare workflow. So workflow consists of the operation workflow, there is a financial workflow, there is nursing workflow. So it's non-patient fronting. And a lot of these hospital data right now is sensitive. So if you say, oh, I'm going to upload to the cloud, people get very anxious. The finance team get very anxious. The HR team that manages the doctor's pay, and they get very anxious. I said, I'm not going to actually upload all these things into the cloud. So how are you going to actually leverage on the Gen AI engines to handle all these unmet need and sensitive data? Pharmaceutical companies like Roche, for example, they have a lot of proprietary, highly confidential data that they cannot actually expose that to the cloud. So how do you actually handle all this sensitive data? And can we actually have a new way to train the foundation models, or like to train to leverage on the technical foundation models to fine-tune certain layers to make it extremely task-specific while reducing the hallucination risk. So this is one of the other, like the big part that we're talking about. And how do we make it fast? How do we make it cheap? And how do we make it evidence-based or referenceable? I mean, this is what we're talking about. And so Enigma, we're trying to actually build that to connect with PDF copies, to Excel sheets, to Microsoft Words, to Progress databases and SAP system that is heavily used by for the financial operations. And this is some of the target use cases outside the hospital settings, outside SingHealth, that we hope this new startup can actually do. So leveraging on pharmaceutical, the industry, the health insurance, as well as the research and clinical operations as well. So for internally for SingHealth, we have leveraged on this technology to help us with our clinical audits. Why is clinical audits important? As a surgeon, we always have to benchmark our surgical performance against the international standards. We pride ourselves to be ranked number 2 in the world because we are very transparent. Every single cataract surgeries that we do in SNEC is being recorded in the videos. If there's anything that goes wrong, we can always pull back the videos and see what the surgeon has done correctly or done wrongly. So this is where we provide a full transparency and like the assurance to the Singaporean population as well as the international population who comes to the Singapore National Eye Centre to see us, so that we can make sure that the clinical and the surgical standards that we offer the patients is at the world-class standards. And we have leveraged on Enigma to actually power through 7.2 thousand cataract surgeries that resulted in 1.2 million rows of your EMR raw data. So if you ask a clinical audit team to power through the 1.2 million rows and then to ask them, hey, maybe you have to search for these 300 pre-existing eye conditions to get excluded from the final calculations, they are taking a lot of time. So the time taken for them to do that is about 500 plus hours in our pilot settings. And using Enigma, using the agentic AI related workflow, we managed to actually reduce that down to only 7 hours. So it's more than 90% reductions in work, the manpower taken in terms of the workflow. This is non-patient fronting. Is there any risk in the patient's care? The short answer is no, but does it actually improve the life for the hospital operation, the clinical staff, the administrators? The short answer is yes. So we are actually currently trying to expand it to the the workflow in SNEC and SingHealth as well. Hopefully, it also in collaboration with MOH and Synapse. Mermaid is another one. It's currently in R&D. We have just finished the development of the technology. We now currently preparing the manuscript. We have already filed the technical disclosure as well. So if you look at foundation models, so these are my 2 other colleagues in Stanford, right? We talked about Stanford. Darius was from there. Fei Lee, Kurt, and Nigam. So I think they are a strong advocate for foundation models. Why is it important? Because with foundation model, with domain-specific foundation model, the numbers of data sets that you need to train a good model is significantly reduced. This is what has been proven in many literature. So what is the unmet need that why do we want another foundation models from Singapore? So I think right now the unmet need is that a lot of foundation models are domain-specific foundation model. Ophthalmology, we have one. Radiology, they have another, like from the Kurtz group, but we do not have the cross-specialty, multi-disease, multi-specialty foundation model. And this is what we aspire to build, the world's largest foundation model right now to cater for different disease domains. So as you can tell from the slides, we trained it with more than 3.3 million data points, medical imaging centric across 7 medical imaging modalities. And this is how we are actually built the technical backbone. It leverages on the vision transformer models. On the medical imaging side is a contrastive deep learning, the strategy with a FIFO update and the memory modules. That actually reduces the risk of catastrophic forgetting from a technical standpoint. And this is the performance of our models. I also want to caution about this AUC of 1.0.99 is too good to be true, because all these the data sets we are currently are tested on the public domain data sets. It's not the real world data sets. So the next phase for us to do is to actually then use these foundation models to start validating and testing that in the real world database. ELF, Vision Language Foundation Model.